right, so I tried to make this practical so that you would benefit from what we know as a field, and then really what we most use is clinician expertise in how we treat, how we use psychotropic medications in our kids with IBD. So here are my disclosures. All the medications mentioned, almost all, will be off-label. So when I was organizing this talk, I tried to focus on what you might, as gastroenterologists, treat the most and use psychotropic medications yourselves to treat. So that's mood, pain, and mood being sort of depression, anxiety, and then sleep we really just talked about. So sleep is there, but not a focus of this talk. I thought of the 6 factors that as I'm making a decision when I get a patient referred and I'm going to start usually an antidepressant, the 6 most important factors that I use as decision points is how much life stress is going on, early childhood adversity, how is the child perceiving their illness, so how negative, pessimistic are they about their illness in general, either in conjunction with these 4 areas or just by itself. How much inflammation is going on, whether the child is on steroids. And genetics, we're a couple years away in psychiatry with psychopharmacogenomics, where we'll take a blood sample and decide which antidepressant is most likely to have produce an optimal response. But for now, our genetics is based on family history. Life stress is important because antidepressant medication is not going to be enough. Early adversity, we know more and more primes the nervous system to be hyperactive, and we don't tend to get as strong a response to any of our psychotropics if there's been significant childhood adversity, and the side effects. The brain seems to be much more reactive to side effects. And the illness perception is important because that too takes separate talk therapy, and most patients' pessimism is not addressed by a dose of Prozac. So I tried to make this case-based. So you're going to have 2 cases. The first case has inactive IBD. It can be really, in this case, we can put them on any of your medications except steroids. We'll tackle steroids later. And they can have anxiety, depression, pain, any 1, 2, or 3 in combo. So I think for most of you, this is not, again, and you can sort of put your own details, but this is not something atypical that you might come across. And whatever combination of these syndromes they have, and we also are assuming that you all have screening techniques, you have your thresholds for when you think that there's a mood, anxiety, or pain problem that is interfering functioning enough that actually warrants a medication intervention. This is how we might decide. We're not talking about psychotherapy, but even in our own trials for anxiety, depression, and increasingly for pain, any medication you give performs better, the child functions better, the symptom improves better if it's given adjunctively with psychotherapy. Back to the medications. So there's tricyclics, there's SSRIs, and SNRIs. I picked these 3 classes because I did a chart review of 1,000 patients, young adults and adolescents in our adult database, and about 400 of them were on psychotropics. This is before my involvement at University of Pittsburgh, and they were mainly prescribed by gastroenterologists and PCPs. 65% were on SSRIs, about 15% were on SNRIs, about 25% together with these other agents were on tricyclics, and a smattering was on bupropion. So we think about the SSRI can be effective for depression, especially if it's anxiety. There's nothing more effective for anxiety than our SSRIs. If we have pain, though, they really do not seem to have any direct effect on pain except by making the patient's emotional state better. So if there's pain involved, especially if it's functional pain, we're thinking about an SNRI or a tricyclic. With the tricyclics, and we're going to go over that in more detail, for pain and actually for insomnia, the lower doses, so really tiny 25 to 50 milligram doses, so about 1/3 the dose you'd use for an antidepressant effect is effective. For depression, you need much higher doses that have very high side effects, so that if you're thinking about depression and pain, we really are thinking about the SNRIs because they're just much better tolerated, and duloxetine really is the one that has been most studied for pain syndromes of all of the SNRIs. All of them have side effects. The tricyclics, as you escalate the dose, have the most troubling side effects. But the SSRIs and SNRIs can both have GI side effects, especially the first 2 weeks. They also, the SSRIs, SNRIs, have minimal risk of the patient actually successfully using them to commit suicide. And we'll talk about suicide a little bit later. The tricyclics are cheaper, but again, they're sort of, as you escalate the dose, the highest risk. Now, when I said a patient presenting with anxiety, often kids don't fit into the nice little boxes we try to draw with our diagnostic criteria. So these are all reasons. I polled some of my colleagues who prescribe these medications a lot. And excessive interpersonal sensitivity, fear, apprehension, dread, shyness, worry, exaggerated physical complaints, sleep, eating problems, excessive need for reassurance, explosive outbursts, and avoidance. These are all ways that if it's excessive, constant, and interferes with functioning, we might actually target with a psychotropic medication if a behavioral intervention isn't working. Now, we don't have a lot to go on with our patients with IBD, and what we have to go on are case series in adults showing SSRIs, SNRIs, and bupropion having some promise, being tolerated by our patients, no randomized trials in either adults or kids, and I told you about our medical record review. Again, SSRIs and SNRIs and bupropion are the 3 most commonly used by all of you, so that's what we'll focus on. So which SSRIs have FDA approval? So this is on-label use, mainly for OCD. OCD absolutely requires behavioral therapy. I would not recommend treating OCD in your GI practices. Fluoxetine and Citalopram are the only 2 that have FDA approval for adolescents with depression, and none of the SSRIs have FDA approval for the non-OCD anxiety disorders. However, we do have some strong randomized trials, and basically they didn't get approval not because they were not safe, but because it wasn't really cost-effective for companies to pursue those label indications. But we do have the agents here, and you see the different agents here, and basically when you look across the trial, there really is no magic formula of which SSRI works best for which condition. It's often, even with us, the experts, trial and error, using the family history and using them in small doses and increasing the dose basically to tolerability slowly and observing for side effects. So we're finding even in our own trials that we haven't often taken the doses high enough, and the doses are the ones that are recommended from these trials. So when you do have an anxiety disorder, the SSRIs are the first medication of choice. I'll show you some augmentation strategies, but again, that's sort of moving in the realm that probably should be getting close to outside your comfort range because you're getting into much more complicated medications and unlikely other psychiatric comorbidity. So these are the doses, and you have these all in your slides that you'll get, but these are the doses that have been sort of proven for the different SSRIs to randomized trial. So 40 milligrams of fluoxetine up to 150 of fluvoxamine, sertraline up to 150. And even at these doses, so these are the therapeutic doses for most kids for anxiety disorder, activation, so hyperactivity, agitation, increased irritability is common in 10 to 15%. True bipolar switch is very uncommon, occurring in less than 1% of patients, and often it's because we missed the diagnosis of bipolar disorder, which can have a more subtle presentation in kids, but it's still something above and beyond just annoying oppositionality or irritability. The GI side effects do occur, nausea, sometimes actually abdominal pain will be worse, but these tend to subside in the first 2 weeks of using these agents. In our kids, especially if on steroids, there are some case series about easier bruising, bloody noses. It really hasn't been consistently reported, and it certainly hasn't gotten any black box warning. And then we're going to talk about suicidality, but the take-home message I'm going to emphasize is when you look at studies that were done, and this is why we have the black box warning for suicidality, there seems to be a signal of increased suicidal ideation and behavior. We're talking 2 out of 100,000 or 4 out of 100,000 compared to the 2 out of the 100,000 in the placebo group, but no committed completed suicides have been linked to the use, and they looked at sort of all antidepressants, so not just the SSRIs. Citalopram has a new warning. So we were often dosing even in 60 milligrams when we were using this for severe anxiety and depression, but there's some very significant data out there showing that you get prolongation of the QT interval as you go up on the dose past 40 milligrams. So we have all stopped doing that. It's not worth the risk. And we actually don't use citalopram if there's a cardiac history or a family history of a significant cardiac problem. Just because there's so many other agents out there, why risk it? So SSRI activation most commonly occurs at its most severe up to 72 hours. It can happen either in the initiation of the therapy or during dose changes. And it usually subsides. So it's important to put this in the context to educate patients and their families. And we do have some non-SSRI, non-activating agents. You see there mirtazapine, which especially is effective for anorexia, nausea, and diarrhea symptoms, just sort of has a secondary benefit, and duloxetine if there's pain. The tricyclics can be activating, though they are usually, it's a paradoxical activation. They're sedating. The tertiary ones like amitriptyline are more sedating than the secondary ones, and sometimes we use that as a benefit to help kids, especially if they're not sleeping from either functional pain or anxiety. Again, like I said in my previous talk, we prime the pump. We don't try to keep them on them for long-term periods, but just to get them really conditioned to fall asleep easier. Now, in summary of the first case, there really is no formula, so we can use the SSRIs. We're going to talk about dosing of the SSRIs related to this case. It really doesn't change with inflammation. It just changed with sort of realistic expectations of what you might see. And again, the SSRIs really don't work for pain. So a 16-year-old male with IBD and depression, and the choice points here are whether there's active inflammation or not, how severe any comorbid anxiety is, and comorbid abdominal pain, and then we'll end with the special case of if they're on steroids for treatment, where we usually see doses of 20 milligram and above equivalents. We can see some significant effects, psychiatric effects that we actually do sometimes treat with medication. So depression in IBD is challenging because the neurovegetative symptoms, the fatigue, sleep disturbance, even the mood, certainly concentration, anhedonia, can be directly resulting from just being sick. And so it's a very fine line. And some of the work that we are doing is sort of past the initial stage of when a child is hospitalized or on really high-dose steroids, sort of the starting doses. You want to be shut down. You want that energy conserved to go to fight the disease in your body. So we're really not talking about intervening with psychotropics then. We are talking about, it takes a while to get back from a flare completely to remission. So as the disease activity is coming down but not completely down, we are finding that aggressive treatment, and we've looked a lot at bupropion, but actually every single antidepressant has some anti-inflammatory effects in the viscera. These are various mice models. We don't know yet how much that helps or hurts us, but I think it really is important that we as a field don't know how, but to be thinking about what you're giving them for their brain is also affecting their gut, and hopefully in positive ways. And then we have the cognitive symptoms, the hopelessness, suicidality, despair, and worthlessness that can occur either when they're sick, but in a paper that we have coming out, in about 8% of kids, they can be actively suicidal and their disease be in relative remission. So it isn't just due to disease parameters. So here are some decision trees that hopefully will be helpful and I think would have the most support. If they have inactive IBD, then an SSRI is first line. If they have active IBD, I would use bupropion as a first line. If there's not sort of severe anorexia, bupropion is dopaminergic. It can cause some slight appetite suppression. It also has moderate anti-TNF properties, separate from what it's doing dopaminergically. And some of the open trials, they are not randomized trials, but there's some at least support for this hypothesis in adults that they're with Crohn's disease, that the IBD activity also improved. It's not out there again. I mean, this is just clinical judgment, but it's well tolerated. It helps a lot with fatigue, which a lot of our kids have with active IBD. If there's severe comorbid anxiety to this depression, then SSRI alone, or it acts by such a different mechanism that we do safely combine SNRIs with bupropion. There's very little overlap in terms of side effects. And then if comorbid pain, we would combine these agents with an SNRI, or again, a low-dose tricyclic. For depression, SSRI, if you're going to respond to an antidepressant, 60% of kids will respond, whichever one. Paxil has some anticholinergic, or paroxetine, sorry, has anticholinergic properties. And your first choice, if your first SSRI doesn't work, is your second SSRI. So they all target serotonin. They don't target them exactly the same way, and there's different degrees of sort of dirtiness to them, even though they're predominantly serotonergic. They're not exclusively serotonergic. And so your second line choice, if there's not a response to a first SSRI, is the second SSRI, followed by, again, an SNRI, duloxetine, usually, again, in the range of 20 to 40 milligrams for an antidepressant dose, bupropion, 150 to 300 milligrams, sometimes pushed to 450, and Celogene is a MAOI inhibitor that we were all afraid of for a long time in terms of the potential serious side effects that we could have with MAOI inhibition. Now, however, it's come out in a transdermal patch that is relatively well tolerated, and it can be a very, very effective medication for non-responsive depression. There's basically an antidepressant, like in your field, we have a drug coming out about every 2 months, and none of them are tested in kids, and usually are not even tested in open trials for 2 to 3 years when they enter the market. So for pediatric depression, with any of these medications, early response at 12 weeks predicts a greater remission at 24 weeks. So you really want to be, if you start these medications, track your kids. And here are, again, collectively from the trials out there, you start a medication, the more severe the baseline depression, the least likely you're going to get a great response. If there's baseline suicidality, we know that that is a predictor for not as good response. Severe anhedonia, so not taking pleasure in things. Hopelessness, the more comorbid psychiatric diagnosis you have, and family conflict. So if there's stress in the background, we really want to, again, address that and not rely on the drug. Here, and you have this in your handouts, the black box warning goes into more detail, but I really covered it. There was a slight, so 2 instead of 4, and that should be 100,000, not 100, rate of suicidal thoughts and behaviors, but no completed suicide. And actually, when this warning came out, all of us, including in psychiatry, stopped using the antidepressants. And there's actually now, it's showing that our kids are having, even outside IBD, higher rates of depression and IBD, and suicidal, not just ideation, but attempts. If you're using these drugs, you really have to have some kind of spiel about home safety. Adolescents are much more likely to kill themselves with firearms, especially if they're males, females by overdose, and children actually by strangulation. So you really need to, if you have any question that the depression could lead to suicide, here are some safety risks, and then monitoring is key. This is a poor slide, I apologize, but if you see citalopram, sertraline had positive effects in our own rigorous randomized trials for depression. Every single other trial that we have done, well done randomized trial for any other antidepressant that's been studied is negative. It means we did not have a statistically significant impact on depression. Here, again, and we've covered most of this, but it just shows you starting doses. You're starting really, really low. 20% of kids can have a response from these agents, even at a very low dose. And taking them up, and again, reminding you of the FDA approval parameters. And then the last piece that I'm going to cover is the steroids. So, okay, I'll wrap it up. So with steroids, there are some indications for targeting certain aspects of sleep disturbance, if there's extreme irritability, and if there's extreme concentration difficulties or fatigue. We dose these medications basically to treat steroid side effects, and we taper them when the kids are coming off the steroids, and the kids do very well, and we take them to the doses needed for effect. So when to consult a psychiatrist, again, really for anything that's other than what I just talked about, certainly for augmentation strategies, and again, to remind you that the psychopharm should be part of a comprehensive biopsychosocial plan. So, thank you.